Good afternoon, everyone. My name is Danny Shouhed. I'm part of the SAGES Foregut Committee. We're here at SAGES 2019, part of the Trailblazer project for Foregut Surgery, and I had the honor and privilege of interviewing Dr. Nat Soper from Northwestern University. He's a professor of surgery, and he's also the general surgery program director at Northwestern. So we'll get started. Dr. Soper, how did you enter the field of foregut surgery? And what got you interested in it to begin with?
So I was trained in the pre-laparoscopy days, and my first faculty job was at WashU in St. Louis to do maximally invasive surgery. But I'd done research in GI. I considered myself a GI surgeon. Then the lap chole revolution came along, and I was fortunate enough to be one of the first academic surgeons to jump into that field. And so all other things fell away because there was such a demand to do laparoscopic cholecystectomy specifically. But we also developed a laboratory, and we were trying all kinds of other crazy things in the lab, and had a big lab budget from industry as we were helping them make instruments and that sort of thing as well. I then heard from good friends John Hunter and Lee Swanstrom that they were starting to do some work on doing fundoplication in animals, thinking about bringing that out in adults. And then Bernard Dallamagna's paper came out in 1991 with the first report of the laparoscopic Nissen fundoplication. And that made me say, wow, this is something we need to do. And we were doing very few Nissens, and in our institution they were all done by the thoracic surgeons. But we also had a very advanced group of gastroenterologists there, one of whom, Ray Klaus, was one of the first GI people doing high-res manometry. So we had a big practice of people coming into the esophageal group. I then started doing these in animals, got VHS tapes from Lee and John, and worked with the gynecologists and things in terms of port placement and things, but just started doing them clinically in humans, and our results were excellent from day one, and it took off, and all of a sudden the volume of laparoscopic fundoplications just exploded. And by the time I left WashU 15 years ago, the GI surgeons were doing 99% of the fundoplications at that time.
Amazing. So, Dr. Soper, what do you consider to be the indications for anti-reflux surgery?
Well, number one is the person has to have reflux, and so you have to prove that they have reflux. Number two, it needs to be significant enough reflux to warrant doing something about it with a procedure, because all procedures can have problems. So it can't just be a little bit of heartburn every once in a while. And we always try people on antacids, PPIs, and things first as a trial. And if they're perfectly satisfied on PPI, then I don't push them to do anything else. If that's not the case, or they want to get off PPIs, or they have ongoing breakthrough symptoms, then I think it's very appropriate to consider somebody for an anti-reflux operation. And at that point, then we have to evaluate them to make sure that they're good candidates. So prove they have reflux. Number one, endoscopy, to look for esophagitis, look for hiatal hernia, look for Barrett's, look for something else that might change what we do. If they have significant esophagitis, hiatal hernia, and typical symptoms, I don't think we need to do a 24-hour pH test. That's proof enough, because people don't like to do that, and it's expensive. If they're atypical symptoms or no esophagitis, then we do a pH test to prove they have reflux. And then I believe every patient on whom you're going to do a foregut operation should have manometry if the patient can tolerate it. Number one, for baseline, in case there's a problem later. If you don't know what it was pre-op, you don't know then how you've affected it. Number two, there are the rare patients who have horrible motility, even though they have minimal symptoms, and manometry will help you figure that out. Barium swallow I do selectively, particularly in people who have big hiatal hernias, so I can see what it looks like myself, see the morphology, see if there's any volvulus, things of that nature, things that, and look for another evidence of a short esophagus, so I can better plan, make sure that we're ready to do a lengthening procedure if need be. And then finally, if they have a lot of nausea or belching or things, we'll do a gastric emptying test. But again, that's pretty uncommon.
Perfect. Just to shift gears out to the actual surgical procedure, in your view, what are the key aspects of the operation that you would want people learning the operation to know and do?
So I think first is preparing the patient for surgery and setting up the operating room. Because I've had both rotator cuffs repaired, I think from bad ergonomics over 30 years. I usually have the patient with spread legs, stand between the patient's legs, but then make sure that the height of the table is appropriate so that you don't have your shoulders elevated, your elbows need to be in at the body, and you need to have a comfortable view of where the TV camera or where the TV screen is. But also then significant, I like to put them in significant reverse Trendelenburg position, as much to help exposure of the diaphragm and the crura and the upper stomach, but also to bring the patient's thorax closer to you. So again, you're not doing something like this. So that's number one, and then gain access, of course. We then take down the pars flaccida, and I approach the right crus first. I know a number of people approach the left crus first. If there's not a sizable hiatal hernia, then we divide the frontoesophageal membrane, come across and mobilize the very top part of the greater curve away from the diaphragm, just so there's a little mobility at the EGJ for when we're doing later stuff. If there's a big hiatal hernia, then that's a very different thing, and maybe we can get into that later. But then I start the dissection again along the right crus and separate the esophagus from the right crus using blunt dissection. If it's a primary operation, not a redo, it should be a vascular tissue. I do what I call the breaststroke, so it's kind of like this, all blunt. I try to identify the posterior vagus as soon as I can, because then I use that as a dissection plane. So I actually use the side of an instrument to kind of push that away so that you can get behind the posterior vagus nerve and that edge of the esophagus, and then go around anteriorly and back to the left side. On the left side, I cross my hands a little bit, lift up on that left crus, and then try and dissect the esophagus down, trying to make sure the anterior vagus nerve is not adherent to the inner aspect of the left crus, because it often is. Identify the anterior vagus, and then we've done that initial dissection of the lower esophagus, identifying both vagus nerves and doing an initial mobilization. The next step then is to mobilize the fundus. So we go down. There's no set location on the greater curve of the stomach, but just something that looks about right. Pick it up, divide short gastrics I usually use a harmonic scalpel of some sort, or rather harmonic shears of some sort. Get into the lesser sac as quickly as possible, because once you're there, you know the anatomy. If you're really struggling in a big fatty omentum and fatty greater curve, it can be a problem. So you want to get into that lesser sac, and then just follow that up to the base of the left crus. And that's really important. I think even if you have a fairly mobile fundus, I still think it's important to do that mobilization, but also it helps get you to the base of the left crus easily. And then you can do your posterior dissection as well. At that point, then, what you have to do is make sure that everything is mobilized and you have enough intra-abdominal esophagus so that you can put a wrap around it and stays in the abdomen. So usually 2.5 to 3 centimeters minimum. In every textbook you'll see people put a Penrose drain around the lower esophagus and pull. I usually don't do that to finish the mobilization unless it's really a short esophagus and we have to get so high. But usually I just pull the fundus around and use that as a retractor, and then go up as high as possible on the esophagus, let it go, make sure that with no traction on it whatsoever, there is at least that amount of esophagus in the abdomen. And if there's not, then you have to mobilize more, do a lengthening procedure or something.
How often do you see yourself doing a lengthening procedure along those lines?
Lengthening procedures, in my experience, are between 5 and 10%, but it's usually in the big paraesophageals, not in the standard Nissen for reflux or something like that.
Got it.
So that's all the mobilization. I mean, what you're trying to do is eliminate tension both on the axial esophagus, but also rotational on the fundus. Again, we pulled the fundus around, we do the Shouhed maneuver and all that kind of stuff, but we then use that fundus to retract the lower esophagus and put stitches in the crura. I tend to use braided polyester sutures, O or 2O. I do intracorporeal suturing and knotting, and always put at least one suture posteriorly and one suture anteriorly. Usually it's, I think our average is 2 posterior and 1 anterior. I like to put that anterior suture in to create a little scar tissue there as well, because most of the recurrences are anterior. Whether that does anything, I don't know. And what you don't want to do, though, is if it's a big hiatal hernia, do everything posterior and really angulate the esophagus. So if you're putting in a bunch of stitches, from time to time I let everything go and make sure that it looks as though the esophagus is in a fairly straight line and orientation coming down.
To avoid that speed bump.
To avoid the speed bump and the angulation. I do not put a dilator in while we close the crura. What we try to do is have the crura just touch the walls of the empty esophagus.
Got it.
You can put 5mm instruments in and around, and it's going to be fine. And we will put a dilator in later, so I'm not worried about it. Then we do the actual fundoplication itself. I tend to use 3 interrupted sutures of 2O braided polyester again, with at least one of the sutures catching the anterior wall of the esophagus.
Got it.
And try and make the wrap 2 centimeters or less in length. So pull it around, do the Shouhed, make sure everything moves 1 to 1, that you can see that you now have, you don't have any redundant fundus that's going to be flipping up posteriorly. The first stitch is probably the most important one, and I usually do where the short gastrics were on both the left and right side, rather than the anterior posterior that Demeester has espoused. Put the first stitch in and then really look at it and make sure you've set it up right. And then you decide whether that first stitch is your middle one or your lower one or your upper one, depending on how things look, and then put in 2 more, each about half a centimeter apart, and again, at least one of them catches the anterior wall of the esophagus. And I forgot to mention that while doing all this, we have a dilator that's been placed. So before putting any stitches in, we have the anesthesiologist, if they feel comfortable, we usually have them put down a 50 French initially to make sure it goes down pretty easily, and with that relatively small dilator, it doesn't look like it's ready to rip through the esophagus because the esophagus is so small. And then in a woman, I usually use a 56 French, and a man usually a 60 French, and do the wrap around that.
Beautiful. Okay, and last question for me, Dr. Soper. So how do you choose between doing a full Nissen 360 wrap versus a partial fundoplication in your patients?
So the bottom line is I prefer to use a Nissen in everybody I think I can. And the reason for that, in my hands, we've published previously that the toupees fail more frequently over time. And I think that makes sense if you're sewing the stomach to the wall of the esophagus rather than seromuscular bite to seromuscular bite with a Nissen fundoplication, because we're all scared we're going to rip the esophageal wall. So I try to do the Nissen. The people in whom I'll do a toupee or sometimes a door, but usually toupee, are those patients who have either significant dysphagia pre-op and somewhat disordered motility. Those people who have virtually no motility, even if they have no dysphagia, and we've had several of those where they say they have no dysphagia and all 10 swallows fail, and you go, how in the world are you doing this? I'll do a partial. And the other group that I'll do a partial in are those people who are really aerophagic. So I ask everybody pre-op, do you have a lot of belching, a lot of bloating? And some people that's a dominant symptom. And in those patients, I just worry that we'll saddle them with significant gas bloat if we do a Nissen fundoplication.
Good afternoon. I'm Edward Aoyang from the University of New Mexico, and again we are here with Dr. Nat Soper, Professor of Surgery at Northwestern University, continuing our discussion on his approach towards reflux disease and anti-reflux surgery. So in the first half, we had discussed kind of your approach to the patient who was having an operation for the first time. What do you see as the main causes for failure of an anti-reflux procedure, and what is your approach towards potentially patients who need revisional operations?
I think there are two main causes for failure. One is poor technique in the first operation, and the second is just simply the senescence of human tissues over time, that we're using human tissue rather than putting in prosthetic material or something, and sutures can pull through, come out, there could be tension on things. Probably that it's the tension that causes the pull through of things. So, you know, what I see is a short esophagus as a main cause of recurrent hiatal hernia, inadequate closure of the hiatus, probably tight fundoplications causing bad dysphagia. The other thing that I've seen on several occasions is essentially creating a slipped wrap de novo, that is wrapping the fundus to the body of the stomach so it's down low and you actually end up with an hourglass stomach. So I think those are the primary things that I've seen, but the most common abnormality we see is a recurrent hiatal hernia with or without disruption of the fundoplication.
Sure. And if a patient comes to you with recurrent symptoms, what is your sort of approach to them? Do you consider offering them a revisional operation? What's your decision making in that process?
So, number one, I have a long talk with them about the impact of a revisional operation and the potential risks of it. So I go through my actual spiel is, first time around it takes 90 minutes, the second time around it takes 3 hours. The first time around there's less than a 1% conversion rate, second time around it's 5 to 10%. First time around the complication rate is less than 1%, the second time it's 5 to 10%. First time around the failure rate is about 1% per year, the second time around it's double that. So I try to really put out the black crepe for them to say, if you don't really need an operation, we shouldn't do an operation. And if they have reflux symptoms as the reason they want it done, we can almost always take care of that with medications. But what almost always requires an operation is severe dysphagia and pain. Those are the two things that patients will ultimately insist on having something done because of that. And the other thing I ask them is, you know, if normally your quality of life is 100, where are you? Are you at 20? Are you an 80? And if they say they're a 90, I say, I can't make you much better than a 90, right? And so your life has to suck for us to go through this together. And then the other thing is I make sure they know that it's a team thing. And most of them are overweight, they're in poor physical condition. I say, for us to do this, you need to lose X amount of weight to get down to a BMI less than 35, and I want you in better condition before we do anything. And then decide, you know, what evaluation would need to be done.
Sure. Great pieces of advice. So over your career, what kind of changes have you seen in the treatment of reflux disease? Are there modifications you've made in your own practice based off of these things? What kind of things have you seen from that standpoint?
Well, it's been interesting because there has been, when we first started doing them, there was a huge increase in the number of these operations that were being done. And then I think perhaps as a result of failures, the GI guys said, wait a minute, we're not going to be sending this many people to the surgeons after all because of problems that they saw. And so it really went down and has plateaued. The other thing is I think we understand more what we're doing. Certainly early on, some of the techniques and technologies needed to be improved to really increase the ease of the operations and the safety of the operations and stuff like that, including the development of some of the thermal devices that we use and things of that nature. But also, we've seen a change in the patients themselves, what they want. And there's a whole split. Some people are happy to be on PPIs forever. Others hear the news about maybe pneumonia, dementia, renal failure, osteoporosis, and say, I want to get off it. And we've also seen the development of some alternative treatments that may or may not be good, and that has also influenced kind of how we manage these.
Sure. What do you see as the future directions for practitioners who are helping to manage this type of disease?
Well, there certainly is a lot of enthusiasm now for the magnetic sphincter augmentation devices. And there was, here at SAGES 2019, there was a big session today talking about that, and a lot of enthusiasm for the magnetic devices. And I can tell you our GI guys like that too, and the reason they like it is because it takes the variability out of it. Because what they see are all the bad things that happen, you know, and have people sent in from all around the region with problems post-fundoplication. And they believe that if surgeons would just put in that magnetic ring and do that in a standard way, then the outcomes would be standardized and better. I think we're going to continue to see alternative modes of treatment coming along, trying to supplant the fundoplications because of the side effects and poor outcomes. You know, all the endoscopic techniques that have been devised so far, I haven't seen one that's really great. I think ultimately we'll see that the fundoplications are reserved for the worst patients, and that the ones with less severe disease will have an alternative treatment.
Final question is, what kind of advice do you have for a trainee or young surgeon who's aspiring to become an expert in anti-reflux surgery?
Well, I think it's important to understand the anatomy and physiology very, very distinctly. Understand the tests that are done and why. Really listen to the patients when they come in, because they often will be telling you things that should really help you decide whether to operate or not, and also, if so, are you going to do a complete or a partial, or are you going to recommend something else being done? And then the other one is don't cut corners. You know, either in ordering the tests that need to be done for you to feel comfortable. I mean, so many patients are sent to me, they've had a manometry done in an outside institution, that I look at the traces and they're terrible. I mean, it's a bad study, and the patient doesn't want to have it done again, but I insist, look, we got to have it done the right way so I really know what's going on. And don't cut corners in the operation either. Sometimes in a redo, it'll be a long operation. You're pooped toward the end, and and you want to get out of the operating room, but you got to make sure that you hang in there and do everything you can to make sure that it's done right the first time. Because if you don't do it right, the patient really pays a pretty high price.
Dr. Soper, thank you again for all of your great advice and for your time. This is reporting from SAGES, Baltimore 2019 for the SAGES Foregut Task Force.
And Ed,
Fathers in Foregut Surgery.
And Ed, thanks for giving me the opportunity to appear. This has been great.